Good afternoon, everybody. First of all, I would like to thank very much the organizers, in particular the Professor Odd Gilia and the Professor Kim Leland for their kind invitation and at this important meeting. My task here is to tell you something about the sonographic assessment of intestinal fibrosis in Crohn's disease. As you know, Crohn's disease is a chronic inflammation characterized by inflammatory relapsing activity causing a progressive and irreversible damage of the bowel. The first step of this chronic irreversible damage is the development of stricture here, where acute and chronic inflammation are combined with fibrosis and sometimes associated with penetrating complications like fistulas and abscesses, leading a high risk of surgery. In fact, this is particularly true for ileal Crohn's disease, which is usually an inflammatory disease at the diagnosis, but becomes transient and penetrating, in other terms complicated by strictures and then fistulas and abscesses during the following 15 years in almost patients, as you can see here in this slide. Therefore, it's not surprising that strictures with or without penetrating complications are the main indication for surgeries, and that up to 70% of patients during their life undergo a surgical operation for this complication, as shown in this study published many years ago. However, strictures in Crohn's disease are not always an irreversible condition. From the histological point of view, Crohn's disease-associated strictures are a transmural process characterized by an overlap between inflammation and fibrosis. And fibrosis and inflammation consist in a variable degree even in the same patient, like in this case where you can see a mild, moderate, and severe grade of fibrosis staining in blue. As reported in this important study, also smooth muscle hypertrophy and hyperplasia are the most prominent histological changes in fibrostenosing bowel stricture. And not only. In Crohn's disease, we can find, along with the active and chronic inflammation and fibrosis, also neuronal hyperplasia and adipose tissue hyperplasia. And all these ingredients concur in variable degrees to produce the thickening of the bowel wall and the narrowing of the lumen. Is determining the thickening of the wall is of utmost importance. Fibrosis is not treatable so far, while inflammation can be reduced with therapy. And if we know how much is fibrosis and inflammation, we know how much we can improve the thickening. Because even only a bit improvement in the thickening can produce a large increase in the luminal area, as you can see in this slide. And so with ultrasound, we can detect strictures. EFSA guidelines state that thickening bowel walls, narrowing of the lumen, and peristenotic dilatation are the main features of the bowel wall strictures. And in particular, with these specific findings, with this definition, we can assess a stricture with a high sensitivity and high specificity, quite comparable to that of MRI and CT. Here are some examples of stricture. As you can see here, this is a stricture with a wide dilatation with fluid content. And here another short stricture in a patient with a bowel occlusion. As you can see here, there is a lot of fluid here and also here, and this is also due to the presence of a stricture here that as you can see is clearly different from the first one. And in the other slide, you can see another stricture here with a lot of mesenteric fat hypertrophy. Here is the huge dilatation with a lot of gaseous content within. So using this definition, you can assess the presence of the stricture with a very high sensitivity and specificity. Using these criteria in particular, it is possible to detect the presence of a stricture with a sensitivity greater than 80%. But if we consider only the stricture that underwent surgery, so the more severe stricture that we can see in our practice, as you can see here, the sensitivity is always greater than 90%. And to improve the sensitivity, namely to reduce the rate of false negative results, in examples when you have a patient with clinically suspected stricture but negative ultrasound examination or the absence of significant dilatation, you can use the oral contrast agent. This is a useful addition able to increase the accuracy of up to 15%. And oral contrast agent is also useful to detect a patient with more than one stricture, up to 20%. And on account of all these findings, the ECHO-ESGAR guidelines state that ultrasound and MRI are the preferred technique to assess this complication. But how we can discriminate and detect fibrosis in Crohn's disease? Or how we can suspect the prevalent fibrotic component in stricture like those we have seen before? We can use the echo pattern, the vascularization assessed by color Doppler or mainly with a contrast-enhanced ultrasound, or elastography. Regarding the echo pattern, years ago we showed that in a series of 43 patients with a single ileal stricture who underwent surgical resection, the echo pattern of the bowel wall just before the prestenotic dilatation, in particular the loss of stratification or its persistence, could suggest its histological features. Namely, the stratified echo pattern was more correlated with fibrosis than the disruption or hypoechoic echo pattern. As you can see here, in particular, using a specific and validated histological score, we found that the echo pattern was not significantly different for several histological features of the bowel wall, such as edema, chronic and acute inflammatory infiltrate, mucosal erosions and ulcers, but was significantly different in the presence of fibrosis of the muscularis mucosa and submucosa. And here you can find that the presence of stratification was much more represented in patients with an increased degree of fibrosis exactly in the muscularis mucosa or submucosa. Regarding the thickening of the muscularis propria that is clearly visible with ultrasound, in this preliminary study for Bergen that assessed 14 patients treated with steroid or biological therapy and followed for 1 year, they showed that the bowel wall thickening was not clearly associated with the response to steroids or biological therapy. And also, the submucosa was not correlated with the response. The thickness of the submucosa was not correlated with response. But in turn, there was a significant inverse correlation of the response with the thickness of the muscularis propria, as you can see in this slide. And if you remember the first study I've cited before, you could understand how important is this point in discriminating stricture responsive and not responsive to the treatment. As you can see here, this is a stricture. This is the stratification of the bowel wall, and in the study stratification of the bowel wall, you can see clearly the muscularis that usually hypertrophied here. So this is a very important point to discriminate for assessing or to have prognostic signs about the response to the therapy and the presence of the fibrosis in our wall. Regarding vascularities, since the 60s, intestinal microvasculature has been considered as an important pathological feature in Crohn's disease. Studies performed with angiography and vascular casts have shown that the disease is associated with vascular changes, namely shunts and microvascular thrombi in the bowel wall, as demonstrated in this slide. Later has been observed that this lesion can occur more frequently and more pronounced in patients with active disease, as you can see here, and these changes are strictly correlated with inflammatory cytokines, upregulation of vascular growth factor, and neoangiogenesis, clearly shown in this slide. Therefore, with the use of intravenous contrast agent, it has been seen that there were highly vascularized Crohn's disease segments, like this one, that meant activity, and other strictures less vascularized that were likely more fibrotic. However, as you could see here, it's sometimes very difficult to assess qualitatively the blood flow within the wall, like in these two different strictures, one inflammatory and the other one fibrotic. And for this reason, several parameters have been identified to describe and give an estimation of the flow, such as the wash-in, the washout rate, the time to peak, the peak enhancement, the other area under the curve, and so on. And all these parameters have been used in the following studies. In fact, using some of these parameters, the first study investigated the correlation between the blood flow within the wall of the stricture and the histology of the stricture, show positive and very promising results. As you can see here, the EFSO guideline recommendation in 2017 stated that GIUS could be used to discriminate between fibrous and inflammatory strictures in Crohn's disease. However, the following and other studies after 2017 show less encouraging results, as you can see here. And in particular, the last one by Roon-Wilkins. In particular, the last study from Roon-Wilkins is worth noting. In this study that correlated the histology of the strictures and the vascularity detected by GIUS and MRI, showed that several GIUS parameters like this that were used to characterize the stricture didn't find any correlation with the histological nature of the stricture, like acute inflammation and fibrosis. There were found some correlation with the fecal calprotectin, but not with clinical and biochemical index like C-reactive protein. And more important, also for MRE parameters, the same study didn't show any correlation between any parameter assessed by MRE and acute inflammation and fibrosis in the bowel wall. And also, the study didn't show any correlation with fecal calprotectin, but found some correlation with the Crohn's disease activity index. And for this reason, relative contrast enhancement of ultrasound and MRE cannot distinguish, according to this study, between inflammatory activity or fibrosis. Regarding the elasticity, now this can be assessed by using elastography. We have two kinds of elastographies. One is strain elastography and the other shear wave elastography. Strain elastography investigates the stiffness of the bowel wall by means of repeated pressure with a probe of the abdominal wall of the patient. The systems inform the operator when the signals is stable and reliable or reproducible. At this point, the image is captured and analyzed. For convention, the blue means hard and the red the soft tissue. And it is possible not only to have a qualitative or subjective, of course, assessment of the stiffness by examining the colors, but also to have a qualitative examination and estimation of the stiffness by comparing the value of the strain within a specific region of interest taken within the wall, and another one similar region of interest outside of the wall, taken from the softer tissue around. The other tool is a shear wave elastography. With this specific tool, we don't need to push or give a repetitive pressure with a probe on the abdominal wall, because the system calculates directly the elasticity in kilopascal, the diffusion of the beam within the tissue in specific regions of interest, as you can see here. The first study used to assess the elasticity in Crohn's disease was published 5 years ago and assessed the strictures in Crohn's disease patients by strain elastography, comparing the results with the rate of fibrosis assessed by histology. As you can see in this scatter plot, the ileal wall fibrosis percentages, as calculated by qualitative analysis of histological sections, show a significant and positive correlation with ileal strain ratios at elastography. After this study, other 5 studies have been published on the same topic, and the results of this study have been considered in this recent meta-analysis, whose conclusion has some limitation due to small size of patients included in the study, the heterogeneity given by different elastography equipments, the different reference standard, and more important, the fact that in this study, the patients were not included consecutively, but are rather selected. Anyway, 3 studies, including that of Mirella Fraquelli, use strain elastography and show a borderline significant results in discriminating patients with fibrosis. Namely, strain was higher in patients with fibrotic stricture than in patients with non-fibrotic stricture. And nearly the same was for shear wave elastography, where the strain value was higher in fibrotic stricture compared to controls with non-fibrotic stricture, but here with a borderline and not significant value. So when we find a possible stricture like this, we should first confirm the presence of a stricture, also by detecting the presence of prestenotic dilatation, and also assess the length of the stricture, like here, because if short, like in this case, we can also consider a pneumatic dilatation, and more important, we have, of course, to define the nature of the stricture. And for this, we could assess the echo pattern of the bowel wall, here is stratified, the vascularization with the color Doppler or with GIUS, and the elasticity with a shear wave or strain elastography, also with qualitative assessment like in this case. This is the so-called multimodal approach. But how accurate and effective is still this approach is far from to be demonstrated. In particular, its impact on our practice remains largely uninvestigated so far, at least for one single experience. In fact, regarding the use of ultrasound, in particular elastography, to assess the response of therapy, there is a study published 2 years ago where 31 patients without stricture in this case were assessed by strain elastography before a biologic treatment and then reassessed at 3 and 12 months later. Bowel wall thickening and strain ratio have been assessed before the treatment, at 3 months and at 12 months. And again here the stenosis were excluded. And this study showed that the baseline bowel wall thickening was not different in patients who responded to the treatment and the patient who underwent operation. On the contrary, the baseline strain ratio was higher in patients who did not respond and underwent operation compared to the patients that were not operated. And again, the tissue or transmural healing, was correlated with the strain ratio. In fact, the patient who did not reach transmural healing show a higher strain ratio compared to the patient who reached transmural healing. And you can see here that the rate of reoperation in the following 2 years was significantly correlated with an increased strain ratio above 2. So far, the ECHO-EXACT guideline that I can remind you stated that cross-sectional imaging should be used to detect strictures, okay, and ultrasound and MRI are the preferred technique, but so far no imaging technique is currently used for detecting and suggesting the degree of fibrosis in our patients. And so, for concluding, I have to tell you that the assessment of fibrosis in Crohn's disease is of course a difficult task, also because we lack of validated histopathological indices. And ultrasound, like MRI, offer of course a promising multimodal approach to assess fibrosis, but to date there are not validated and useful scores that can be used in our clinical practice. Thank you for your attention.